So the standard output speed of an ECG machine is 25 millimeter per second. What does this mean? 25 millimeter per second means 5 large squares or 25 small squares are equal to 1 second. So 25 small squares are equal to 1 second. Then one small square will be equal to 0.04 second. And 5 large square is equal to 1 second. So one large square will be equal to 0.2 second or 200 millisecond. So how to calculate rate from ECG? It's very simple. There are 3 methods to calculate the rate. Either we count the large squares between two RR intervals, between two consecutive RR waves, or we calculate the RR interval, the large boxes in the RR interval, such as in this case. How many large boxes are present between this R and this R? Can anyone tell me? Yes, almost 4. 1, 2, 3, 4, 5. It's 5 large boxes. Kindly zoom the picture if you, yes, 5 large boxes or large squares between two R waves. So if we are calculating the large squares, then we divide it on 300. The number of large square divided by 300. What will be the heart rate? 300 divided by 5. 300 divided by 5. What will be the answer? 60. So the heart rate in this ECG is 60. The number of large squares between two R waves are divided by 300. Such as in this case, there are 5 large squares. So 300 divided by 5, it's 60. The heart rate is 60, almost 60. This was the first method to calculate the heart rate. But if the patient heart rate is increased or the patient is having tachycardia, then the accurate method to calculate the heart rate is to count the number of small squares between two R waves. Because if a person has tachycardia, then there are usually 1.5 large box or 1.75 large boxes. So it's better to calculate small squares in this scenario to calculate the heart rate accurately. Now count the small squares between two R waves. How many small squares? 27. Excellent. If we calculate small squares, then we divide it on 1500. 1500 divided by 27. 1500 divided by 27. 1500 divided by 27. The answer is almost 56. Yes, 56 approximately. Five large squares are equal to 1 second. 5 large squares are equal to 1 second. How many large squares will be equal to 1 minute? 300 large square will be equal to 1 minute. That's why it's 300. And 1500 small squares will be equal to 1 minute. That's why it's 1500 if we calculate the small squares. The third method is if the heart rate is irregular. If the heart rhythm is irregular, then how we calculate the heart rate? If the RR interval is irregular, then how we calculate the heart rate? If the heart rate is irregular, then we calculate the heart rate by counting the number of R waves in the rhythm strip in a 10 second long rhythm strip. So if the heart rate is irregular, or the heart rhythm is irregular, or the RR interval is irregular, we calculate the heart rate by counting the number of R waves in the rhythm strip, which is usually at the bottom of the ECG, and lead 2 in the ECG is usually a rhythm strip. And it is usually 10 second long. So 1 second contain 5 large boxes, and 10 second will contain 50 large boxes. So we calculate the number of R waves in a 10 second long strip or in 50 large boxes and divide it or multiply it by 6. Not divide it, multiply it by 6. Because the number of R wave for 10 seconds, and if we multiply it by 6, it will give an approximate heart rate for 1 minute. So this one is a rhythm strip, and it contains almost 50 large squares. So 50 large squares is equal to 10 seconds. Now we need to calculate the R waves, the total number of R waves in a 10 second strip. The total number of R waves in a 10 second strip in this ECG is 9. We will multiply this 9 by 6. And the heart rate will be 54. So there are 3 methods to calculate the heart rate. There are 3 methods to calculate the heart rate. One is to count the large squares between 2 R waves and divide it on 300, or count the small squares between 2 R waves and divide it on 1500, or if the heart rate is, or if the heart rhythm is irregular, or the RR interval is irregular, then we count the number of R waves in a 10 second ECG and multiply it by we calculate the number of R waves in a 10 second step and multiply it by 6. So that's how we get the heart rate if the rhythm is irregular. So how to calculate the heart rate? Is it clear to everyone? The last method is used when the heart rhythm is irregular. If the heart rhythm is irregular, means RR interval is not regular. RR interval is not regular, then we RR interval are irregular, then we use the 10 second strip method. We calculate the number of R waves, the total number of R waves in a 10-second strip, which is the rhythm strip, and the rhythm strip is usually 10-second long. It is given at the bottom of the ECG, and it is lead number 2, or limb lead 2 is usually used as a rhythm strip, and it is usually 10-second long. So we calculate the total number of R waves in a rhythm strip, which in this case is the total number of R wave in the rhythm strip is 9. As we calculated the number of R waves mean the number of beats. One R wave represent one heartbeat. So we have calculated the number of our heartbeats in 10 seconds, which is 9. And for 1 minute, we will multiply it by 6. So there are 9 beats or 9 R waves in 10 seconds. How many beats or how many R waves will be in 1 minute? We'll get it by multiplying the number of R waves with 6. Is it clear now? If the heart rate is irregular, we use the 10-second method. Because we have counted the number of R waves in 10 seconds, 10 second or 50 large squares. 10 multiplied by 6 is 60 seconds. So we count the number of R waves and multiply it by 6 to get a heart rate or number of beats in 1 minute. Because 10 seconds multiplied by 6, we will get 60 seconds. Is there any question? Any more questions? So the first thing that we do in an ECG is to calculate the heart rate. From the rate, we can have an estimate. Yes, we need to always multiply it with 6. And we need to always calculate the number of R waves in a 10-second strip if the heart rate is irregular, or the heart rhythm is irregular, or the RR interval is irregular. So the first thing that we need to do in an ECG is to calculate the heart rate. From the rate, we can have an idea that is it a normal heart rate, is it a tachycardia, or is it a bradycardia? So by calculating the heart rate, we can have an idea about any irregularity. The second thing that we need to see in an ECG is rhythm. After rate, we see the rhythm. How we see the rhythm? We see the rhythm by seeing that if the RR interval are regular or not. First of all, we see the P wave. If the P wave is present, then we say that this is a sinus rhythm, a rhythm that is originating from SA node. If the P wave is, and if the P wave is not present, then it is arrhythmia. And in which condition P wave is not present? Atrial fibrillation. So let's see the RR interval in this ECG. This RR interval almost have 5 large squares. or 27 small squares. This other interval is 27 small squares long. This one is also 1, 2, 3, 4, 5. Yes, the rhythm is regular because all the RR interval are 27 small scales long or 5 large scales long. So after calculating the heart rate, we see the rhythm of the heart if it's regular or not. If the P wave is present, then it is sinus rhythm. And if the RR interval is regular, then we call it as normal sinus rhythm. And there is only one condition in which there is irregular heart rate or irregular rhythm, that is atrial fibrillation. The rate and the rhythm are best analyzed by looking at the rhythm strip on a 12 lead ECG. This is usually a 10-second recording from lead 2. So the rhythm strip, as I told you before, that the rhythm strip is on a standard ECG, the rhythm strip is normally the recording from lead 2, a 10-second long recording from the lead 2. The third thing that we need to assess in a ECG is access, cardiac access. Before we do cardiac access, let me show you the position of different ECG, the placement of different ECG leads. These are chest leads. The heart is like this from here to here. The anatomical position of the heart is like this. The heart is lying like this in chest cavity, and these are the precordial or chest leads. Lead V1 is placed. Lead V1 is placed in the fourth intercostal space on the right costal margin. Lead 2 is placed in the fourth intercostal space on the left costal margin. Now see the placement of lead V4, 5, and 6. Lead V4 is placed between in the mid clavicular line, a line that passes from the middle of the clavicle. Lead V4 is placed in the fifth intercostal space in mid clavicular line. Lead V5 is placed in the anterior axillary line, and lead V6 is made in the mid axillary line. The leads are placed such that V1 and V2 are a recording potential or electric voltage from the septum of the heart. V3 and V4 from the anterior surface of heart, and V5 and V6, they look at the heart from a lateral position. If the heart is lying like that, these two leads are looking at the heart from a lateral position. So that's why these two leads are for septal myocardial infarction. This is for anterior, and these four are anterior septal, V1, V2, V3, and V4, and V5 and V6, because they are looking at the heart from a lateral position. So if there are changes, any changes in V5 and V6, then we say that it's a lateral wall MI. Now let's look at the limb leads. There are 6 limb leads. There are 6 limb leads. 3 limb leads are bipolar, and 3 limb leads are unipolar. The bipolar limb leads have two electrodes, and the unipolar limb leads have one electrode, which is the positive one. Now, first of all, how a lead 1 is placed. Lead 1 has a positive terminal at right arm, positive terminal at right arm, and negative at left arm. So lead 1 has a positive terminal at right arm and, sorry, lead 1 has a positive terminal at left arm, this is left arm, and this is the right arm, and negative terminal at right arm. The second bipolar limb lead, lead number 2, has a positive terminal at left foot, lead 1 has a positive terminal on the left arm here. This is left side, this is right side. So lead 1 has a positive terminal on the on the left arm and negative terminal on the right arm. This is lead 1. Now look at lead 2. Lead 1 has a positive terminal at the left arm and lead 2 has a positive terminal on the left foot. So 1 has a positive terminal on left arm and 2 has a positive terminal on left foot. And both of them have their negative terminal on the right arm. The third bipolar limb lead, which is lead 3. Lead 3 also have its positive terminal on left foot like lead 2. But its negative terminal is on left arm. So these were the three bipolar limb leads. I just repeat it. Lead 1 has a positive terminal on the left arm and negative on the right arm. Lead 2 has a positive terminal on left foot and negative on the right arm. Lead 3 has a positive terminal on the foot and negative on the left arm. So now can you see that in the chest leads we saw that V5 and V6 were looking at the heart from a lateral position, or they were looking at the lateral wall of the heart, lead V5 and V6. Now, as I told you that lead 1 has a positive terminal here on the left arm. So lead 1 is also looking at the heart from a lateral position because the arm is lateral to the heart. Heart is lying here and this lead is looking from this position, so it is looking at the lateral wall of the heart. So along with V5 and V6, another lateral lead is lead 1 or limb lead 1. Is that clear? Now you know the three lateral leads, V5, V6 and lead 1. So if there are any changes in lead V5, V6 or lead 1, then you will say that it's lateral wall MI. Because all three of them are looking at the heart from a lateral position. Now, yes, lateral side. Now, you know that lead 2 and lead 3 has a positive terminal on left foot. Lead 2 and lead 3 has a positive terminal on left foot. So which surface? Yes, inferior surface. They are looking at the inferior surface of the heart, lead 2 and lead 3. So if there is any change in lead 2 and lead 3, then you can say that the inferior wall of the heart is involved. Is that right? Is everyone clear about it? So now we'll discuss about the unipolar limb leads. The unipolar limb leads V3, V3, just look at the V3. Yes, I forgot to tell you about V3. V3 is placed between V4 and V2. No, look at V3. It's lying directly anterior to the heart. Here is the anterior surface of the heart. Lead V3 and V4 are lying directly anterior to the heart. Bipolar means bipolar have two electrodes, one positive electrode and one negative electrode. And unipolar have only one electrode, the positive one. So that's why they are called unipolar limb leads and bipolar limb leads. So now we are doing now unipolar limb leads. There are three unipolar limb leads, AVF, AVL, and AVR. Very simple. AVF means the positive terminal of AVF is on left foot. F represents the foot. The positive terminal of AVF, augmented vector foot or augmented vector left foot, because in all the 12 leads, right leg is not counted. So it's understood that AVF means left foot, the unipolar limb lead, which has its positive terminal on the left foot. So now we have the third lead for the inferior wall. The previous two were 2 and 3, and now for the inferior wall, a third lead is included, which is AVF. Because 2, 3, and AVF, all of them have their positive terminal on the left foot. So they look at the inferior surface of the heart. They, they see the heart from below. So that's why if there are any changes in 2, 3, and AVF, then we'll say that it's inferior wall MI, or the inferior wall of the heart is involved. Now AVL, AVL and AVR, very simple. Now it's turn of the arms. AVL mean augmented limb lead, which has its positive terminal on L or left arm. Remember the name and you will remember that where it has its positive terminal. So AVL is also looking at the heart from a lateral surface. So now can anyone tell me what are the 4 lateral leads? Tell me about the 4 lateral leads, which have their positive terminal or which look at the heart from a lateral surface of V5 and V6 from chest leads. And from limb leads, which 2 leads have their positive terminal on the left arm? One AVL. So one AVL, V5 and 6 are lateral leads, and 2, 3 AVF are inferior leads. Is that right? Now the 6th limb lead, which is AVR, as its name shows that it has its positive terminal. It has its positive terminal on right arm, R for right arm, L for left arm, F for left foot. So I hope that now everyone know the placement of different leads of ECG and how they are related to different walls of the heart. Is there any confusion so far? You can say that AVR is superior. There is no lateral valve on the right side, and it is at the top, is looking at the heart from the top like this. So that's why it's not included in the lateral leads. The lateral surface of the heart is on the left side, or the lateral wall you can say is on the left side. So anything or any lead which are present on the left side, lateral to the heart, or looking at the lateral surface, only they will be included in the lateral wall MI or changes in the lateral wall. So remember that AVR is kind of superior. AVR has a superior view of the heart. It's important to remember it. I'll tell you in the coming slides why it's important to remember that it is a superior wave or superior lead. Any more questions? No questions? So the third thing that we are going to discuss, we need to do or need to see in an ECG or need to assess on an ECG. The first thing was rate, the second was rhythm, and the third one is access. Third one is access. How to know about the access deviation? This circle represent, suppose this is a circle around the heart. Here the heart is lying like this. What is cardiac axis? Normally the cardiac axis is directed downward and towards the left. This half is represent the left half and this one is the right half. This one is the left half. So normally the cardiac axis is directed downward and